Bom, gente, depois destes modelos locais, dessas experiências brasileiras, nós vamos conhecer mais de uma experiência que vem de longe, vem da África. E, para tanto, nós temos como convidado especial hoje, ele que é diretor executivo do Ubora Institute e também um dos fundadores do projeto Fives Alive em Gana. Então, muito bem-vindo, Ernest Kanyoke, para falar sobre o desafio da melhoria na África.
Thank you and good afternoon. Yes, it's a special privilege for me to join you today in the first international meeting for the Safe Patient Project. I would, in the course of the next 30 minutes, share some experiences with you on some of the challenges of improving quality and safety of healthcare in Africa, with some specific cases in mind. So, as introduced, I am Ernest Kanyoke. I'm director for Ubora Institute. Ubora Institute is a regionally based quality institute that is set up to support all kinds of quality improvement programs in Africa. We are based in Accra, Ghana, and actually we set up after the successful implementation of the Fives Alive project, which was over a period of 7 years, trying to improve child health in Ghana. As part of what we do, we deliver educational content and quality improvement. We also facilitate learning opportunities for individuals, organizations, to learn quality improvement implementation and support them to be able to take these type of innovations to scale. We have a strategic partnership with the Institute for Healthcare Improvement in terms of delivering all kinds of work. Currently, we have in the last 1 year after our establishment, we have worked in Nigeria, Ghana, we are working in India, we have worked in Namibia, and then, of course, Ethiopia. Okay, so this is the African context. Africa, we know, is the second largest continent in land area and in population of nearly 1.2 billion, with about 54 countries spread around. And what is remarkable about Africa is that the population in Africa is growing. It has a very relatively young population. The median age in Africa, as of 2012, is about just under 20 years, when the world is doing about 30. So significantly lower average. And it is a country that varies, depending on where you are. There are huge variations in Africa. In terms of the languages, the culture, economics, and a lot of historical ties due to the legacy of colonization. So in terms of the experiences I'll be sharing with you, I'm going to share them actually based on my experience working on the Fives Alive project extensively in Ghana, and then our increasing work with IHI and other partners across the continent. If you look on the African map, with all those countries that are highlighted in the various colors, that is currently where the Institute for Healthcare Improvement is working actively in Africa. We are not working with them in terms of supporting this type of work all over those countries. The specific countries that we are helping to deliver work are countries like in West Africa, which is in Liberia, where we are helping to deliver a collaborative to improve a range of things in healthcare, including infection prevention and control, improve maternal health, child health services, and then improve malaria, and then also improve patient and family-centered care. In Namibia, we are supporting Health Qual and the ministry to also reduce the loss to HIV retention, to improve HIV retention, and then improve viral load suppression. We also have a lot of support we do in terms of improvement capability, supporting the various programs to build improvement capability across a range of countries, beyond those countries that are highlighted. Our Ethiopia project is led by IHI, which is engaging the ministry, and that is also supposed to improve maternal and neonatal health outcomes. So most of these experiences I will share with you will basically emanate from the 7 years of work we did in 5 Alive, and the little over 1.5 years of work we have been doing with IHI in some of these other countries. The real challenge in Africa has to do with a gap. Now, over time, Africa is doing reasonably better than it used to do in terms of the quality and safety of healthcare. But you will realize that there is a growing gap between what we know works in terms of evidence based on research and a lot of small projects that have happened over time, and what we are actually doing to be able to close the gap in terms of the results. And that growing gap is emerging. The challenge for us in Africa is that sometimes the categorization of the problems could be seen in 4 main areas. One is about access to healthcare. So you have a service, it's supposed to reduce morbidity, reduce mortality. The question is it accessible to all the populations? Usually not. So a lot of systems are struggling, and a lot of programs are on the ground and are supposed to accelerate how you can provide access, improve coverages of healthcare services. Whether it is in maternal and child health services, it is in infection prevention and control, it is in mental health, or all those other thematic areas. The other part is the quality of the services that are being provided, and this is very more, so to speak, more institutional. As and when some of these populations or the clients or the patients come to us, are we able to deliver effective and safe care? And that's where patient safety really comes in very strongly. And there are growing gaps. I mean, in most of the countries in Africa, you would realize that you would go and you ask for some kind of data on medication errors. There's nothing. Nobody collects data on that. You know, surgical errors. All you know is that there are increasing medical legal cases against all kinds of service providers for some incidents that happen, but there's no database to access that. There is a gap. So there are issues. We also know that there are a lot of services that are being provided, and yet we are not quite seeing the direct impact in terms of the results on reducing mortalities or the morbidities, corresponding mortalities and morbidities. And another bigger problem is in the area of reliability of the healthcare services. Some of these services are delivered to the various populations or the patients, and they are not usually delivered all the time. So, for instance, actively on weekdays, it's very common for services to be very good, and then at weekends, the service is not just existent, you know. So there are all those type of issues. And whether those services are provided for everybody, is it for probably the educated class, or is it for a particular section of the population? Is it for the urban people and not the rural people? So you have all these observable gaps. But at the heart of this, as we have been interacting today, is the issue about putting the patient or the client in the center of healthcare. And this is really a journey that in our continent in Africa, we really still struggling a bit because it is something that is more provider-driven. So healthcare is seen as, oh, it's the doctor who says it all. So when the doctor gives you medication, you probably will not even ask him or her, oh, what is this medication for? So it is centered more around providers rather than the patient. But there is this growing trend to reverse it. So all these issues, I would say, are basically the broad categories we can appreciate the African problem in terms of improving healthcare. Okay. So this is a very emphatic statement that was made, and it calls for some reflection. Somewhere in December 2009, the African Academies of Sciences met in Accra, Ghana, where I work, And then they stated that 4 million women, newborns, and children in Africa south of the Sahara die every year, or could be saved every year if we have well-established healthcare that is currently available, and if these interventions could be implemented across the whole region. And this is really a very compelling statement. And so I would like us to focus on a country situation in Ghana where we work extensively. So Ghana is a country which is nearly 30 million people. If you look at the graph at the top left-hand corner, these are trends in terms of improving services, in terms of access, provision of services. So the coverages are improving for absolute coverage of antenatal care, which is the top line. We also have the 4 visits, because the World Health Organization encourages a minimum of 4 visits for women who are in prenatal care. And we have seen that over time, there has been improving. And then even access to what we call facility delivery. Deliveries attended by a skilled staff have also significantly improved. However, if you look down where you have the corresponding mortalities related to that, what we realize is that most of these mortalities haven't decreased much compared to the magnitude of improvement we have achieved. So, and this is the real challenge. And Ghana, I would say, is relatively a better country in terms of these indicators. And so you can even begin to appreciate, for instance, what happens in the various parts of Africa. I think Ghana is probably the best country in terms of these indicators in West Africa, among the 16 countries, and more so in much of Africa. So it is clear that, yes, there are a number of initiatives that have been implemented. We are getting some results, but the question is, could we get better? Do we have a better appreciation of the type of problems we have? And so I would want to see these challenges. I want to outline them on a systems level based on my extensive work with team members of my organization, Ubora Institute, and some of the work I have done as IHI faculty across Africa. First, I would say, is the fragmented approach to quality. Fragmented approach to quality. Usually, what you would see is that a lot of the quality initiatives that are being that are taking place on a continent in the past few years, most of them are usually by partners who get some funding and then partner with governments, and they come and do all kinds of quality work or quality and safety work in various pockets in the various parts of the various nations. The question is, usually the countries lack that overall framework that can guide these partners and the funders to invest and put these initiatives where they are most needed. So you have that lack of an overarching framework that guides all the partners and the donors to be able to focus some of their interventions in specific areas. Number 2, I would say, is that so many a time you have numerous interventions by various partners that are just happening in pockets. So they get fantastic results. They go to 1 or 2 districts or 1 region. They stay there. They work over years. They get fantastic results, but they are not able to carry these results to scale. Because what is needed in Africa is able to carry a lot of these good work, test them across populations, across the various countries, population-wide. And that's where we can really get results that will be measurable and give us the kind of impact we would most want to see. The third is that, just like I've alluded to, much of it is usually partner-driven. So you would see a project maybe funded by the Gates Foundation or the U.S. International, the United Nations, various United Nations agencies, or USAID, or maybe the UK government. And then they are partnering with local organizations or the NGOs, and they are doing work. And so they usually have to go and get buy-in from the various countries, ministries, to do the work. So you see partners being at the front and the ministries just supporting at the back, when actually it should have been the other way around. And that is not really something that is sustainable, because right after this implementation of these projects elapse, usually you have lack of sustainability of a lot of the interventions. And then, just like I also mentioned, you have instances where you have parallel data systems, because a lot of all these initiatives thrive on data, evidence. That is what people use to do active reporting for how utilization of funds are done. However, in the various African countries, the data systems are very weak. They are very focused on the outcomes. They don't collect a lot of community-related data in terms of the metrics. And so they are usually not used by a lot of these initiatives. So you would see a typical not governmental organization doing a lot of good work, and they are collecting parallel data. They invest in collecting parallel data. And right after that, nobody collects the data, and the routine system doesn't really benefit. So you want data to be able to know where you are or what the gaps really are, and you don't have a clear sense of that kind of gap. That is another area that is. So the fifth area I want to focus on is that over a period, since I really started getting very active in healthcare improvement work in some of those countries, is the fact that there's a lot of premium on activities rather than impacts. So you would see typically organizations or partners come and work with the ministries, and they do all kinds of training, safe motherhood. They will do all kinds of patient safety trainings, surgical site infection trainings. So they do trainings, and the data they collect is how many people we have trained, how frequently we have trained. But the question is, what impact is it making? How many falls were we getting? Or how many surgical site infections were we getting? How many are we getting now? That is usually lacking. So there's so much focus on activities rather than impacts and outcomes. And I think that is also something that is very observable across a lot of the programs you see in Africa. And ultimately, there is weak integration of clinical care and then the systems approach. We know that quality improvement teaches a lot of systems appreciation and seeing the healthcare system, not even within just healthcare, but also looking at other social determinants. Looking at it beyond the clinical interventions as to what the doctor does, or what the pediatrician does, or what the neonatologist does, but looking at it as in what are the inputs that are required, what are the outcomes we are getting, is there underutilization of resources, how are we organizing our teams, do they have improvement capability knowledge, can they do PDSAs, can they take local decisions based on some of the weaknesses they are finding in their system, and how are they reading meanings into that, so that they can do some of these really small but very, very compelling type of interventions that can really turn around outcomes. And that for me would be the 6 key problematic areas or the challenges to improvement in the Africa region. And so I would want to just note that indeed we have come a long way in Africa, but there is now a new paradigm. Gradual, it's a transition, yes, but it is beginning to happen. We are beginning to see a network of key stakeholders where there are issues around leadership, there are issues around aligning funding and budgets for this type of improvement work. We have seen increasing engagement of partners from leadership, that is governments and ministries. And then the institution of some kind of a learning system that can really do work, see what works, what doesn't work, be able to carry and actually scale up the scalable interventions that can really produce results. However, all these has to come together in what I would usually call the drivers for improvement, whether there is the will. So in places where you have the will by leadership to bring all these stakeholders together so that we can have a very engaging conversation around doing real work, getting results in the right way, and learning from a system of what works within the context of what is happening in the various areas is a key thing. And of course, the ideas, improvement knowledge. Yes, most instances we have the clinicians, there's a clinical knowledge. We know the standards, we are used to the inspection, quality assurance. Are we able to tie that into quality planning and learn a lot of improvement skills? How do we use the PDAC to learn, to harvest knowledge, and then how do we systematically plan for scale-up? All these things are important. And like I'm talking about scale-up, scale-up is all about having a very good execution strategy. And we are beginning to see that. Our 5 Salai project in Ghana, for instance, by the time we had done scale-up across the country. In the last 2 years of the scale-up, which I will notify here, among 140 hospitals, we achieved as much as a 35% reduction in under 5 mortality across. Even though the project was hitherto running for about 5 years, doing a lot of the work at a smaller scale, by the time we had scaled up, in 2 years, or in 2.5 years, out of the 7 years, we achieved as much as 35% reduction in under 5 mortality. And this was very compelling. And there's this growing movement. We are seeing it in Liberia. We are beginning to see this in Namibia. We are seeing a lot of this in Ethiopia, where there are country-led initiatives to do that. So to summarize, yes, closing the gap, indeed, there are challenges, resources, there are challenges in terms of appreciating the system and learning from it and doing what works within the context. And this is doable. Yes, we can indeed close the gap. Yes, the interventions that work, we know them. How well are we doing them? We can only do this with systems improvement. Thank you.
Nós é que agradecemos. Thank you so much, Ernest Kanyoke, diretor executivo do Ubora Institute. Nós temos alguns minutos para as perguntas e a mediação será da Luciana Yumi Ue, que volta ao palco. Ela que coordena o nosso, que é da equipe técnica do programa Paciente Seguro em nível nacional, lá do Ministério da Saúde. Luciana, bem-vinda mais uma vez. Você já é da casa nesse palco aqui também, já é da casa em Porto Alegre, no palco também.
Reciclada.
Tá certo, tá certo. Por favor.
Queria agradecer primeiramente a sua fala. Ela foi muito esperada e muito desejada por todos nós, porque nós sabemos que temos muitas similaridades. Nós vamos, então, receber as perguntas daqueles que quiserem trazer ao palco. Teremos em torno de 15 minutos para isso. Então, gostaríamos de aproveitar ao máximo a sua presença nesses 2 dias, por todas as curiosidades e porque também gostaríamos de ouvir todas as soluções que podem ser as mesmas entre os nossos continentes. Enquanto isso, eu vou fazer as minhas perguntas. Fiquei muito curiosa sobre o scale-up da metodologia. Como vocês driblaram essa diferença entre países? Ou entre regiões de um mesmo país?
Okay, thank you. Yeah, thank you. The experiences in the various countries are indeed different, but the problems are really never really different. And so, in most countries, you would, whether in East Africa, in West Africa, or in the Southern Africa, the issues, for instance, about the fact that you don't really have a very good or reliable data system is something. And the cross-cutting nature of some of these problems means that how do we put in place a system to even sustainably improve the health information systems, rather than working on the parallel side after the 3 or 4 years of active project implementation. You leave a system without any continuous measurement to see how the system is performing going forward. And so we have worked in the various countries to appreciate that, indeed, one of the key questions to improvement is how you would know a change is an improvement, which is the which is the second question in the model for improvement. And this is usually done in terms of how you engage leadership. the ministry. Do we have data that tells us what the real situation is? If we don't, and we are not convinced, how do we strengthen it? Is there a process we can institute to improve, for instance, the timeliness of the data that is coming in, the completeness of the data that is coming in, and whether that data in itself is accurate? Yes, we have done this before, and I remember in the Ghana situation, all the results I projected in the slides were results that I pulled from the routine data in Ghana. They are not results that we collected as a parallel data as a project. We work with the country, right from the sub-district level, the district level, the regional level, and the national level, to institute what we call a data quality improvement project. And over time, we improved it, such that by the time we had got to scale up, the data was of relatively good quality. But I must admit that this is work in progress. Yes.
Temos aqui mais 3 perguntas, e bem interessantes, acho que também eram dúvidas que vários dos aqui presentes têm. Uma delas, a primeira, é como foram envolvidas as equipes no trabalho da segurança do paciente. How was involved the groups and the teams for the patient safety improvement program?
Okay, so how do we go about forming teams and working with teams in patients' safety or quality improvement programs? This is usually the significant part of any improvement process, how you constitute teams. And I think it's very fundamental because this discussion usually has to start even with leaders. Our strategy in most of the countries I've worked with IHI or I've worked with Ubora, in a lot of the countries that these teams were put in place, is one, to acknowledge that you need a multidisciplinary team. And you need a team that doesn't just meet at the top, which is at the macro level, but you actually need teams that are doing the work at the micro level. So if it is a health center, you need a viable team at the health center. And the 3 key components in terms of this discussion over time, because this is usually a discussion with the various partners, especially led by the ministries, is to acknowledge that, yes, you need leadership at each level. So if you have a team, for instance, at the sub-district level or at the hospital level, you need a management sponsor as a member of that team. Number 2 is that for whichever area you are working in, you need technical experts to be members of that team. So if it is a care process to do with maternal and child health service, then of course, an obstetrician and gynecologist, and then maybe a pediatrician, if you have, will be very important to be a member of the team. And then you usually need somebody who galvanizes the whole team on a day-to-day basis, which usually would come in the form of maybe a data person or somebody who is really passionate about the work, for which the person will not get any extra remuneration. And these things are usually arranged in the form of a program that is outlined. But it is important that it is not done from the perspective of the partner. It is important that this is usually led by the ministry. Tell us who best fits in this role, and let us know how you can create an administrative arrangement where this person can do the work and it doesn't become extra work. You know, these things are very key. And so, for instance, there's a quality strategy that was launched in Ethiopia, and the ministry has actually taken it upon itself to begin to build capability within its own system beyond using partners. And they are creating this arrangement. There was one that was launched in Ghana in December last year. And as part of that, there is a redefinition of the roles within the various agencies within the ministry to look at whether they can have quality teams at each level and who is secretary to the team and all that. And these things are incorporated into their systems of work and their appraisal or performance management systems. So this become integral to their work. That's what I would say.
Muito obrigada. A próxima questão é um problema da segurança do paciente, então por que não conversar sobre isso? Quais foram os canais de comunicação escolhidos nos países por onde vocês tiveram projetos para informar dos avanços e por que eles foram escolhidos no seu contexto?
Can you take that again?
Quais canais de comunicação foram escolhidos para informar sobre os avanços dos projetos e por que foram escolhidos?
Yes. So this is usually, there was a varied approach, I would say. A varied approach in the sense that what pertained in country A was slightly different to what pertained in country B. However, there were very common characteristics in terms of how this happened. So one was to create a dissemination among the participating teams that were doing improvement. So typically in the collaborative, you have things like learning sessions. So a learning session became a very big platform for peer-to-peer learning, of course, but also for peer-to-peer sharing. So that was a very good one, because when you are informed as to what works and how somebody else in your peer facility is doing great work, usually the uptake of that type of innovation is much better. Number two was to create deliberate platforms for sharing. And some of these things were usually opportunities that already existed in the routine system. So typically, most countries that we work would have what we call a review meeting, district review meeting, regional review meeting, and they do them like 2 or 3 times in a year. So within these type of review meetings, the teams and the heads of the various teams will use an opportunity, 1 hour, 2 hours, to come and give a comprehensive report with results and strategy as to what is happening. And then there were also other huge platforms at the national level, where there is a conference, all these type of communications happened, and then even internationally. But for us, what was significant was that there was this ongoing sharing that used to happen, or that happens periodically as part and parcel of the project design, where the design means that stakeholders occasionally should meet, look at what works, what needs to be redesigned, and how people can be kept informed as to what is going on. Well, it promotes trust, it promotes commitment, and then people feel like they are also participating to be informed, the design, and the rollout of a lot of the improvement work. So I think these are the quick platforms I think are common across board, but there are peculiarities depending on the country.
Essa veio em inglês, a gente traduz para o português. Como é que eles conseguiram levar a melhoria para a ponta?
Okay. So, can I take that? Yes. So I have a question here that talks about how you teach, for instance, the model for improvement in front of frontline teams. Well, one thing that is significant that we need to note is that for every audience, there is a type of language they seem to relate to. So knowing your audience is important. And for us, in my experience, in the African sense, in some of the few countries that I've been to teaching this model for improvement, one is to begin to give an example outside of healthcare. So I know I personally used an example like, I want to reduce my weight because I weighed, say, 68 kilograms, and my aim was that in 2 months, I'll reduce my weight to 60 kilograms. So immediately you do this, they become interested in the story you want to give. So in that story, I tell them, how do I know that my weight is 68 kilograms? So you are beginning to ask them about things like setting an aim, which relates to the first question. So it means that I should have measured my weight over a period of time. You get it? So as I explained, I measured my weight in 3 weeks or 4 weeks, and I got my median measurement to be 68 kilograms. They understand that baseline data is important to know what you are doing or how you are performing. Number 2, I will go ahead and say, for instance, how would I know that over the next 2 months, week by week, my weight actually is reducing? Then they kind of brainstorm, then they talk among themselves, and they say, oh, but you need to continue measuring. Oh, so you need to take your weight every day, and in a week, you take the average of that weight, and that will be how you plot it. And I said, oh, okay, so you are beginning to answer the question as to how I will know a change is an improvement. So it is important. So if I'm measuring, what am I measuring? Then I'll ask, so it's my weight. So based on that, I define my indicators or the measures. So I'm able to define what it means to be a numerator, what means a denominator, and whether I'm going to do it as a rate computation times 1,000, or I'm going to do it as a percentage computation, or I'm going to leave it as a number. So you teach it gradually. Then you go, okay, so you ask them, so given that my weight is 68, what can they suggest I should do to reduce my weight? Then they quickly come and say, but you know what, maybe you have been eating too much. You see, they observe that in the last 2 days, you have been having this meeting. You have been eating a lot of snacks, and your lunch is heavy. So you have to cut down the number of calories you are eating. So somebody's talking about reducing the number of calories I'm eating. Then I call it, that's what we call a change idea. Then I go on. So is that all? Somebody says, okay, maybe you don't exercise, because I can see your stomach is bulging. So maybe you're not doing a lot of aerobic exercise. So what should I do? They say, okay, go jogging 30 minutes in the morning before you come and take your shower and come to the meeting. So I said, okay, so all right, jogging every day 30 minutes. Then I ask, so what do I then do? Because you want me to do all this at once? Then they say, no, you try the food for 1 week and then let's see. So trying the food is something you begin to teach them, means that, you have to plan the change idea. So what food should I eat? How much should I not eat? And how often should I eat? So asking the questions as to what, how, who, when. All those things, they help you to write them down. So we do that, then I come up with a prediction. So maybe after the first 2 weeks, I expect my weight to have come down from 68 to maybe 66 kilograms. So for me, it's about teaching an example that sometimes is outside a technical area or outside of healthcare. It makes them appreciate the methodology. And then when you are finished with that, you then go back and then put a real example which is related to the kind of care they are giving. It helps them assimilate the concept much better. So it's actually about demystifying this whole model for improvement, the 3 questions, and what it means to do a PDSA cycle, I would say. That has really done the trick in most instances.
Tem mais perguntas. Eu gostaria de deixar também, poder perguntar depois, conversarmos um pouco, porque são perguntas muito interessantes. É difícil até parar nesse momento, mas estamos perto do almoço. Todos aqui também precisam repor suas energias para a gente voltar. Mas agradecer muito a sua presença e sabemos que temos muito a aprender ainda.
Obrigada mais uma vez, Ernest Kanyoke, diretor executivo do Ubora Institute. Gente, nós terminamos a programação da manhã com um modelo internacional e com essa troca internacional. Vamos começar à tarde também com a participação aqui no palco da Melinda Sawyer, que ela vai falar sobre segurança do paciente, o modelo do Armstrong Institute, lá dos Estados Unidos, ok? Às 14h30. Eu quero pedir, por gentileza, cheguem alguns minutos antes. É bem importante isso para a gente poder ter respeitar, enfim, os horários e a programação, que é bastante intensa. Um pedido, ou uma lembrança, melhor dizendo, temos aqueles pratos especiais no almoço, aqui no andar de baixo, para as pessoas que têm alguma intolerância à lactose ou então ao glúten. E, por gentileza, levem todo o material aqui da sala na hora do almoço. É um pedido da organização. Ótimo almoço a todos.